So I've worked for some years on the genomics of multiple myeloma, and one of the things that changed, we used to use exome sequencing, but now we can do 100% of the genome. Exomes were 2%, and now we're getting information on 100% of the genome. So the depth of the data and what you can do with it has got increasingly large. And so using these features, you can find all of the mutations, and you can find signatures of different mutational drivers. And so myeloma is shaped by 8 specific mutational signatures. The important ones are APOBEC, which seems to be really important in pushing myeloma forward. And some of the other things reflect treatment. So you can see signatures of exposure to the cytotoxic chemotherapy that we use, melphalan. And at relapse, you can see that sometimes relapses are driven by exposure to the treatment. And similarly to chemotherapy, with radiation therapy, there are now signatures which correlate with exposure to the radiation therapy. So that's a big thing. And so in addition to those mutational signatures, there are copy number signatures, and you can use those copy number signatures to detect these complex structural variations. And so they sound as if they're not important, but actually one of them, something called chromothripsis, where one region of the genome is shattered completely, then reassembled and copied abnormally to give multiple copy number changes. Those are associated with very poor outcome. And it's quite frequent in myeloma, so you can put that together with the other sort of common prognostic factors to be able to predict how patients are going to do long term. And at some level, even with these new CAR T therapies and bispecifics, these features are common enough and mediate kind of response so much that they're going to be important prognostic factors. So really, I kind of see a future of using genomics to make clinically useful techniques to allow us to use treatment better in the clinic.